Thank you, Dr. Ravindran. May I please invite Dr. Muhamed Sajid, please?
Good morning, one and all, respected chairpersons, senior professors, dear friends, delegates. First of all, let me thank the Kottayam team for inviting me to give a lecture. This is the topic on which I'm going to talk. Basically, it is to identify the type of surgery that you would like to do based on the recent knowledge that we have acquired related to the various newer surgical procedures that have been described. Warm greetings from MES Medical College. These are the topics on which I will be talking. And as we go through the topics, we will understand a little bit about the concepts that I'm trying to put forth. Any surgery needs to have an understanding of the history of surgery. We all know that parotid surgeries mean surgery of facial nerve. And obviously the problem that we all faced was the problems related to saving facial nerve. It was in 1921 that Sistrunk demonstrated the retrograde surgical procedures, and present surgery that we all follow was actually put forth in 1951 by Hayes Martin. Coming to the newer modalities of surgery, from 1950 onwards, people started questioning the concept of parotidectomies based on what we are doing now. And it was in 1980 that extracapsular dissections have started to come into vogue. So that was actually the basic history for you to understand the surgery. Now, as you know, every surgery needs to have a proper clinical assessment and radiological assessment related to the planning of the type of surgery. So obviously, the clinical assessment would make us differentiate whether it's a benign lesion or a malignant lesion, specifically the lobe which is involved, the position of the lesion in relationship to the nerve, and of course, whether nerve is involved or not. Plenty of discussions related to ultrasound, FNACs with the newer guidelines coming in, with also understanding that FNAC has its own pitfalls many a time. We do see lesions that are described as benign later turning out to be malignant lesions. So obviously the next important question is, are we having investigations to really understand the relationship of facial nerve to the swelling as such? MRI is pretty good in identifying, but however, we need to have special coils for really identifying the relationship of the nerve to the swelling, which many institutions may not have. Now coming into the terminologies, as you can see, plenty of terminologies being described. So there is a big confusion happening, and we all are aware about superficial and deep parotidectomies, conservative, radical, etc. So there is a big confusion that is happening. So for that purpose, I would like to bring into your knowledge a study that has been put forth in 2016 and published by the European Salivary Gland Society related to the classification of parotidectomies. Here the surgeries are divided only into two basic groups. Number one, what is described as parotidectomy, and number two, what we call as extracapsular dissections. So what does this mean? What does this terminologies make you understand? So what they did was that they divided the parotid gland into 4 levels based on its relationship to the divisions of the facial nerve. So a level 1 would be the part of part of the gland related to the superficial to the superior division of facial nerve. Likewise, level 2, which is related to the inferior division, and also the deeper divisions divided into level 3 and level 4. Accessory parotid gland has been given a separate classification as level 5. So based on this, the concept of extracapsular dissection as well as parotidectomy was brought in. So what is parotidectomy? The moment we start identifying the facial nerve and dissect off the facial nerve and then do a parotidectomy, that is classically described as a parotidectomy. But when we do not do a identification of facial nerve and then do a dissection of the levels, and if the dissections need not be even a complete dissections. A partial dissection of a level is also considered as extracapsular dissection. So extracapsular dissection is dissecting outside the capsule of the gland together with removal of any one of these levels. So that is what it means by the two basic terms of extracapsular dissection and parotidectomies. In addition, the ECGS terminology also adds non-parotid structures that are removed. So in the description of surgical nodes, this also will be added. Suppose a branch of facial nerve, say for example, a temporal branch of facial nerve is divided, then you add cranial nerve 7 bracket temporal branch, that means T. So that also is added. Similarly, all the other structures that are removed together with the parotid gland, which are the non-parotid structures, are also part of this description. So this is a comparison of what the ESGS terminology with relationship to the conventional description. So if we are to do a conservative parotidectomy, total parotidectomy, in the newer terminology it will be called as parotidectomy level 1 to 4. Similarly, for extracapsular dissection, if you are doing only level 1, it is called as ECD1 dissection. Likewise, up to ECD4 or 5. So this is basically the comparison and classification. So we will revisit what extracapsular dissection means and what are the indications for extracapsular dissections. Solitary mobile lesions, benign tumors detected by preoperative clinical and radiological diagnosis, and positions preferably in the periphery of the gland, like especially in the tail. These are called as these are ideal indications for extracapsular dissections. Regarding malignancy, we will come to that shortly. There are some scenarios where we may have to do surgery for. Patients who are not candidates for ECD are patients who are having unknown pathology, low-grade malignancies, obviously clear malignancy with high-risk features, and very, very small tumors. So the question will obviously come, what is the benefit of doing extracapsular dissection? There are three benefits that are, the two benefits that are described over a period of time based on this study. What is that is that the incidence of Frey syndrome as well as facial nerve palsy is reduced with this specific type of surgery, and this is shown by this specific study. Regarding malignancy, things are very obvious, but unfortunately in some scenarios what we described as unknown or lesions that are not sure to be malignant, what we describe in the new FNA criteria as SUMP, forms to about 35%, wherein which the initial diagnosis is malignant, is benign but turns malignant. Whether to do a surgery, completion surgery, or should we add up with adjuvant radiotherapy, these are questions that still needs to be answered. So based on this, the summary is that a good pre-operative evaluation remains a key factor in the decision of surgery. A uniformity in terminologies that are needed specifically for analysis of data are to be kept in mind, and now we are aware of the two terms that are described, parotidectomy and extracapsular dissections. The newer procedures obviously reduces the morbidity of the surgery, and approaches to malignancy remain the same except in rare scenarios. Thank you very much.
Any quick remark from the chair, please?
Regarding the extracapsular excision, or you mean dissection or excision? Which terminology you are going to?
Extracapsular dissections are the terms. Basically, it is excision, sir.
Right.
Only thing is that it is not as complete as it is in a parotidectomy.
Yes. Thank you.
In pleomorphic adenoma, which will you suggest, extracapsular dissection or superficial parotidectomy?
Sir, it depends on the site of the lesion. In a scenario where you cannot do extracapsular dissection, we will go ahead with superficial parotidectomy. The problem is the issue related to recurrence.
That is why.
The issue related to recurrence, when we go through the details, what we understand is that the recurrence takes about 48 months, average time of 48 months, number one. Number two, if recurrence were to happen, and if we were to do surgery, these patients will have to go for adjuvant radiotherapy. So obviously, in a scenario where you are unable to do extracapsular dissection, there is nothing wrong in doing a superficial parotidectomy. So we should be prepared to do both. It is not that only in this case we will do like this, we will exactly do like this, is not a right way to put things across.
One final remark from the audience, sir.
Sajid,
Yes, sir.
sir, excellent presentation, extending the frontiers of the surgical procedures. In the extended extracapsular dissection, have you mentioned any incidence of focal neurological deficits, facial nerve?
Sir, the incidence of focal neurological deficits are very, very less when we do extracapsular dissection. The only thing is that it has to be done in a very meticulous way. So that is one of the reasons, based on that study which I showed, one of the reasons why extracapsular dissections have been done is that even the temporary facial nerve palsies are less when it is compared to doing a formal parotidectomy.
Is there a limit to the size of the lesion?
Sir, there is no limit to the size of lesion. In the article which I quoted in ESGS, they have mentioned that there are two limitations of extracapsular dissections, even in scenarios where in which the size is large, you may have to be forced to see the facial nerve.
Thank you, sir.
But still you can do a extracapsular dissection.
Thank you, sir. With the permission of the chair, can we wind up the session, sir?
Okay.
Thank you, everyone.
Thank you so much. I'd like to thank the esteemed chairpersons and speakers of the session.